Hello, my name is Marco Niero, and I'm the CSO of CTF Europe. I wanted to welcome you to this info masterclass, and most especially thank you on behalf of all the patients for your interest in NF. Now, before we move on to the real stuff, I need to give you some instructions regarding the Q&A. You will be able to put down your questions by using the chat box during the masterclass. We would much prefer if you put down these questions in English. If you have trouble formulating your question in English, we could advise you to try to use online translators such as Google Translate before putting them down in the chat box. And if that is not possible for you, please do it in your own language, and we will do our best on our end to have it translated as best as we can into English. Enjoy your masterclass.
Good evening. My name's Andrew King, and I'm Professor of Neurosurgery in Manchester. Thank you for asking me and my colleague from Paris, Michelle Calamarides, to give this talk on surgery in neurofibromatosis type 2. Neurofibromatosis type 2 is a condition characterized by predominantly benign tumors, most notably schwannomas and meningiomas in the central nervous system, as well as peripheral schwannomas. The criteria for diagnosing NF2 are well set and described here. The hallmark is bilateral vestibular schwannomas, but in a given patient, there are other criteria. Thus, in a patient who has a first-degree relative with NF2 and either a single unilateral vestibular schwannoma or any two of meningioma, schwannomas elsewhere, glioma, neurofibroma, and a posterior subcapsular lenticular opacity, the criteria will be met. Another option in a given patient would be a unilateral vestibular schwannoma and any two of the same list I've described above. I would emphasize that a glioma is an extremely rare tumor in NF2 outside of the intrinsic spinal cord gliomas called ependymomas. Another criteria would be a patient with multiple meningiomas and a unilateral vestibular schwannoma or any two of the same list I've described previously. The principles of NF2 management are based around monitoring and, if possible, trying to avoid treatment. Thus, the monitoring consists of regular MRI imaging of the brain and spine, audiological and ophthalmological evaluation, and an awareness of the genetic severity score, which correlates closely with the clinical problems that the patient is likely to suffer. Thus, each tumor is usually annually evaluated in the context of the clinical picture, whether it's becoming symptomatic, whether it's growing, and whether that growth or symptoms are such that treatment is required, most commonly surgery. But I emphasize, the principle is to observe and try and avoid treatment. It is therefore a very different principle to a single tumor in a sporadic case. Thus, a vestibular schwannoma that in a non-NF2 patient would itself merit surgery based on size would commonly be watched to see if it grows over time because of the great enthusiasm for trying to avoid harmful intervention. Even more than the desire to avoid treatment and to maintain observation is the need for expert opinion. And I've tried to demonstrate this over a period of 30 years in England. The left-hand paper from 1993 is from my colleague Gareth Evans and is a statement that there is a need for supraregional care to improve the quality of outcome, and that the occasional NF2 surgeon simply should not exist. This was followed in 2002 by a further paper predicting the risk of death based on whether the patient was managed in a supraregional center of excellence or in a local center. And this Kaplan-Meier curve clearly shows the difference in death, whether it was in a specialist center or not. And ultimately, this led in 2009 to the 4-centre model of NF2 care in England, where £7 million is given nationally to the 4 centres to supervise the care of NF2 patients throughout England. And this has been proven and published to improve mortality and morbidity. It is a rather unusual fact that there is no relation between the size of a vestibular schwannoma and hearing function in that ear. Moreover, there is no relationship between tumor growth of the vestibular schwannoma and hearing in that ear. And there is no link between the behavior of one vestibular schwannoma and the other. Thus, one might grow, the other be stable. The one that is stable might produce hearing loss. The one that is growing and larger might have preserved hearing. And indeed, this is a common challenge in NF2, that the larger, if you like, life-threatening tumor is the only functioning ear, and therefore surgery, as I referred to earlier, may produce or will produce loss of hearing in the only remaining ear. This paper, produced by Michel Calamarides and his colleagues, effectively shows this complete lack of correlation between growth and hearing, and makes an important point that over the years in this left Kaplan-Meier curve, there will be a progressively increasing number of surgeries required for growth and threat to life and limb, whereas in the same group of patients, a large number of them will not actually lose their hearing in the natural history of the disease. And there is therefore a conflict between tumor control and the management of tumor control and the desire to avoid surgery because it will avoid hearing loss. An alternative to surgery is gamma knife radiosurgery. This is effectively a form of radiotherapy, and the term radiosurgery simply means that it is a single dose of radiotherapy. It has the great appeal that one is not resecting the tumor, and therefore, apart from the generalities of undergoing major surgery, one is not potentially causing hearing loss at the time of the treatment, namely the radiosurgery. Its effectiveness, as shown in this paper, is very dependent on the size of the vestibular schwannoma. And the left-hand graph here shows that with larger tumors and more severe type of NF2, the efficacy of control deteriorates. FG is a relatively benign and mild form of neurofibromatosis type 2. W is Wishart, which is much more severe. So in smaller tumors with a mild NF2, the tumor control rate is very effective. With larger tumors with the Wishart variant, i.e. more severe disease, less so. The right-hand Kaplan-Meier makes the important point that even with stereotactic radiosurgery, there is a progressive loss of hearing over time. And I think it is questionable as to whether one retains long-term hearing with gamma knife, even though its enthusiasts certainly argue that it does. The ideal treatment for this severe condition would be to neither operate nor irradiate. Both of these are effectively damaging techniques. Ideal would be a drug without side effects. Well, there's not a drug without side effects, but about 10 years ago, a new drug came onto the armamentarium of options to treat vestibular schwannomas and other schwannomas in NF2, namely bevacizumab. This is a VEGF inhibitor and is given on a regular intravenous basis, usually 2 weekly, sometimes 3 weekly at a varying dose. And this slide demonstrates that in this particular case, it has produced very effective shrinkage of the tumor. This is a graphical representation of 61 patients from the NF2 service in England and describes the control rate of growth based on treatment. There are a few points to make here. There was a total of 61 patients treated, and prior to giving the drug, the growth rate ranged from 12 to 179%, with an average growth rate of 51%. You can see that within the 20% lines either side of stability, the majority of the tumors fall, and thus one got a partial volumetric response in 39% and 51% stabilization of growing tumors. Put another way, whilst on the drug, the majority of the tumors either shrank or stabilized. A small percentage continued to grow. Importantly, hearing was maintained or improved in 81%. I would say that there is some debate as to how long-term that maintenance of hearing is. It certainly can occur, and it can occur reliably, but I think the 81% hearing control is a little optimistic. It is also important to say that when bevacizumab stops, the tumors tend to regrow, but may not do so for some time, perhaps a year or two, and therefore one can have tumor drug breaks. Based on the relative success of bevacizumab, other drugs are being explored. The ideal, of course, would be an oral medication that did not require the patient to come into hospital for an intravenous regime on a regular basis. Thus far, no other drugs have been found with successful evidence of tumor control to the same extent. It is worth saying that bevacizumab has its side effects, most notably proteinuria and the potential for renal damage in the long term, hypertension, and impaired wound healing. Therefore, if the drug fails to control a tumor or another tumor, notably a meningioma, which is not controlled by bevacizumab, the drug needs to be stopped for a period of time beforehand to allow surgery to proceed. Finally, of course, there is the role of surgery in the management of vestibular schwannoma. This can range from bony decompression of the confines of the nerve and the tumor to try and maintain hearing without doing a destructive operation. And Professor Kalamarides will talk about this in his section of the talk. Before one considers surgical resection, which we will go on to, the role of hearing rehabilitation is, of course, central to vestibular schwannoma management and the patients who are suffering from this condition. There are effectively two forms of hearing rehabilitation, namely a cochlear implant, seen here with the cochlear implant going into the curl of the cochlea, and a brainstem implant. The cochlear implant requires an intact cochlear nerve and therefore is not an option if the surgical resection has included the vestibular cochlear nerve. It is sometimes possible to remove the tumor which is growing on the vestibular part of the vestibular cochlear nerve, but preserve the cochlear nerve. But it tends to be a very size-related issue, and therefore the larger the tumor, the less likely it is to do so. A brainstem implant is inserted directly onto the cochlear nucleus in the foramen of Luschka within the brainstem. It therefore is an option for some form of hearing restoration or maintenance, but it is important to note that whereas a cochlear implant often produces hearing of sufficient quality that the patient can, for example, hear on the telephone, this is almost inevitably not the case with a brainstem implant, and the quality of hearing is really a great deal worse. It's better than silence, and in particular, augmented by the ability to lip read, can be transformative to patients' lives, but it is substantially inferior to the role of a cochlear implant. Equally importantly, since the advent of bevacizumab as a way of controlling tumors, the numbers of brainstem implants that have been done, in other words, the number of surgical resections which would render patients deaf, has dropped massively. And in our centers and in Paris and in any other center, the number we are doing now is really very unusual because of the effectiveness of the drug at controlling the tumor and therefore not requiring surgery. Obviously, the primary role of surgery is tumor removal. And ultimately, however, the reality is that a significant number of these patients will require surgery to their vestibular schwannoma. The overarching principle of the decision to operate I've described, namely trying to avoid it unless there is a growing large tumor, with an emphasis on not only large but growing. The principle of the vestibular schwannoma surgery is to remove as much as safely possible. It is occasionally possible to preserve hearing, occasionally possible to preserve the cochlear nerve. But the most important nerve to prioritize routinely is facial nerve function. The facial nerve is draped over the tumor and is therefore at considerable risk of harm. And all surgeons in vestibular schwannoma surgery, whether sporadic or in NF2, will prioritize facial nerve preservation over complete resection. Thus, ideally, one will remove the whole tumor, but if it is felt that this is likely to cause a paralyzed face, then subtotal or near total will aim to be achieved with decompression of the brainstem. Facial nerve paralysis is not only cosmetically unsightly, but if combined with trigeminal loss, the inability to close the eye with a numb cornea can expose to the risk of blindness. And this is the point that I've made in the upper part of this slide, whether it's on the same side or contralateral. The remainder of this talk will be carried on by Michelle Calamarides, describing tumors in NF2 other than vestibular schwannoma and some case examples. So I hand on to Michelle.
Thank you, Andy, my friend, for your beautiful presentation. So now I will continue and finish before the question and answer part. I would like to add to the vestibular schwannoma surgery something we are doing in Paris and in some other center. It's internal auditory canal decompression through a middle fossa approach. We use this technique in case of worsening of hearing or worsening of ARBR for a small or low-growing vestibular schwannoma. Another team in Germany performed this surgery through a retrosigmoid approach, and they show that decompression of the internal auditory canal with some degrees of tumor removal, because they added to the bony decompression some tumor removal, show that it can decrease postoperative tumor growth rate in young NF2 patients. So they use this technique. For us, we use only the bony decompression and dura opening, and it's sometimes very efficient. Now, a few clinical cases just to illustrate our presentation. This is a case of a young NF2 patient. He's 30 years old, no familial history of NF2, and we discover the bilateral vestibular schwannoma because of some dizziness. So after 6 months, the right vestibular schwannoma was growing, and we decided to remove it through a retrosigmoid approach. Preoperatively, the hearing was normal. Tumor removal was total, and we did the surgery under hearing monitoring with ERBR and direct cochlear nerve monitoring. we were able to preserve hearing, and the facial function was totally normal. You can see the post-op MRI on the left with T1 Gado and the audiometry. Something very interesting is the auditory brainstem response. You see, before surgery on the right, waves were delayed, and after surgery, it's normal. So removing the vestibular schwannoma improve the electrical function of the cochlear nerve. On the left side, with a stable tumor, it was before the right VS surgery normal, and now the waves are totally lost. It means that we observe a worsening on the left, and if we decide to remove the left vestibular schwannoma in case of tumor growth, the prognosis of hearing preservation is not so good. It's now the case of a very young NF2 patient. NF2 was discovered when the patient was 2 years old, and observation show a slight tumor growth of both vestibular schwannoma. The patient has some surgical opinion with surgery on the left or on the right, and we discussed the case with Andrew King, and for us, we have definitively to wait to be sure that the tumor will continue to grow, and to let the patient without surgery before being older. We think that hearing loss is a real issue, and even after surgery, tumor can recur, as previously published by the House Clinic. Another case of NF2, it's a young patient, is 28 years old. He had a previous surgery on the left side without hearing preservation, and he was under Avastin for a long time with hydrocephalus. And finally, surgery was decided, and the patient was referred to our center with a very, very big tumor, in fact, many tumors, vestibular schwannoma and trigeminal schwannoma and schwannoma on the lower cranial nerve. So surgery was performed a few days ago, and the patient is still in ICU, but definitively it's very difficult to do surgery with this size of vestibular schwannoma, and surgery should be performed before. Now we move to the second type of tumor in NF2, the meningioma. So some facts about meningioma. The first is that the course of meningiomas in NF2 patient is unpredictable. You can have some meningioma of grade 2 and 3 with some recurrence. In fact, it seems to be not so frequent as for sporadic meningioma. And the last point is that in children, frequently meningioma will be the first tumor in pediatric cases. What are the therapeutical options? As for vestibular schwannoma, we think that observation is necessary and very good to understand the natural history of each meningioma in each patient. We published recently a score to predict the risk of rapid growth of meningioma, and you can see on the graph that in fact the most of meningioma in NF2 patients are slow or not growing. In fact, some meningioma will grow rapidly, and in the score we establish, you see the 4 criteria. It's the diameter of the tumor, so the risk of growth is greater for large meningioma. If there are no calcification, in case of peritumoral edema, and if in T2 you can see hyperintensity or isointensity. So we establish this score to predict the growth and to decide to treat maybe when the tumor starts to grow. What are the options to treat growing meningioma? It's possible to use radiosurgery, gamma knife, cyber knife, or other, or radiotherapy for larger meningioma. It could be used as a first-line treatment for small asymptomatic growing meningioma or in case of recurrence. I don't think that when there is edema, it's good to treat by gamma knife. And when there is a deficit, surgery is mandatory. So there are few options for radiosurgery and radiotherapy, but it can help, especially when the patient don't want anymore any surgery with, small growing meningioma. In this paper, you can see it's relatively efficient to treat meningioma in NF2 patients with radiosurgery. The medical options are less clear than for vestibular schwannoma. Bevacizumab was used, but it doesn't work so nicely as for vestibular schwannoma. The other possibility we use in France is the association of everolimus, is mTOR inhibitor, with octreotide. And this paper published in Clinical Cancer Research 2 years ago shows that this association can improve the survival of patients with meningioma, and a decrease of the growth rate was observed in the meningioma in this cohort of patients. And it works especially for the NF2 mutated meningioma, so for the sporadic and for the NF2 patient. So sometimes when surgery or radiotherapy is not a possibility, we use this association. Maybe something in the future, it's Lutathera treatment. It's a receptor-targeted radiopeptide. So most of the meningioma, in particularly the benign, have somatostatin receptor. And you can see when you are performing a PET datatok in the middle signal. So such meningioma can be treated with Lutathera. And we will see in the future it can work because you can target in one session multiple meningioma. However, as usual, surgery has a great role in meningioma management with some case of tumor removal and ventricular shunting. So what are the indications for surgery in the case of NF2-related meningiomas? Surgery is indicated in case of intracranial hypertension for very large meningioma, or in case of neurological deficit, in case of epilepsy. So it's clearly surgery will need the use of anti-epileptic medication, but sometimes you can cure epilepsy by removing meningioma. And in case of asymptomatic growing meningioma, with or without edema. Clearly, when I follow an NF2 patient and I see a fast-growing meningioma with edema appearance, you know that this meningioma will be symptomatic and you have to treat it. And I prefer to use surgery rather than radiosurgery. But in fact, surgery is in most cases easy. And when you discuss with an NF2 patient, it's not like vestibular schwannoma surgery. However, it can be difficult for sagittal meningioma removal with all the drainage vein and the risk of deficit. in the management of NF2 patient, you have to deal with cerebral venous drainage impairment, because a lot of patients, like in this case, will have meningioma invading the sagittal sinus, and you can have headache, papillar edema, but in some cases, some patients will not have headache, particularly after vestibular schwannoma. And the risk is a blindness with optic atrophy. So ophthalmic follow-up is necessary in patients with multiple meningioma to be sure that there is no papillar edema and no hypertension. In such case, it's not the removal of the meningioma that will cure the patient, and the solution is to put ventricular shunting to decrease pressure in the brain. This is an example of meningioma management in an NF2 patient. You see this right convexity meningioma with a left deficit in the NF2 patient. We remove this tumor to ZZ, but the grading was grade 2. So during the follow-up, we observe recurrence at the margin of the dura mater resection, probably because invasion by tumor cells. We performed gamma knife and it didn't work. Then we did surgery after radiotherapy. And you see another recurrence on the other margin, very close to the sagittal sinus. So we did another gamma knife and it didn't work. And then recently we remove the tumor again, and now it's a grade 3. So we are following the patient. The patient has a left slight deficit. What are the principles of spinal tumor management? The last tumor type we will discuss in this presentation. Some facts. Many NF2 patients have spinal tumors, and most of the spinal tumors are asymptomatic. We think that surgery is indicated only for symptomatic schwannoma and meningioma with spinal cord compression, and in some asymptomatic growing ependymomas, because we know that for ependymoma, it's very rare to improve the neurological situation of the patient. It's totally different with schwannoma and meningioma. When you remove a spinal tumor, you will improve the patient. So for ependymoma, you have to decide to do surgery before the symptoms are appearing. And we did a very nice study with Andrew King team in Manchester, and we showed that surgery for asymptomatic large ependymoma is better for the NF2 patient rather than observation. And we improve the survival of the NF2 patient. So what are the therapeutic options for spinal tumors? Observation, to understand the natural history of each tumor. Radiosurgery or radiotherapy, no, there is no place for such treatment. Medical treatment, bevacizumab, can be useful to treat some growing cystic part of ependymoma, as you can see in this example, and you see the cyst reduction with clinical improvement. And as usual, there is a large place for surgery with tumor removal. So the principle of spinal tumor surgery, it's to remove the meningioma and schwannoma, but you have to consider that sometimes for NF2 schwannoma, the tumor is growing from the Lissauer tractus, and then sometimes the spinal cord can be very compressed, so you have to be very careful, and it's more difficult to remove. I find schwannoma in an NF2 patient compared to sporadic spinal schwannoma. For ependymoma, it's a surgery of intramedullary tumors. So you have to open the posterior part of the spinal cord using the midline, and you can remove the tumor, not the cystic part. And you see two examples of ependymoma. So this is one example of ependymoma. This patient had a non-familial NF2 and I think that the NF2 was discovered because of vestibular schwannoma. And you see on the first MRI, two localizations of ependymoma, one in the cervical part with some cyst and one in the lower thoracic part. And you see on T1. So the patient was followed, but this is MRI 9 years later. But I would say too much follow, because when I see the patient, it had a pre-op deficit. He has a left hemiparesis, and you see that the cervical ependymoma was larger with a large cyst, and it was the same at the thoracic part. So I remove the cervical part, and the patient at the beginning was worsened, and with follow-up now is better. Also, he has always his deficit on the left side. So I consider that in this case, surgery was too late, and it would have been better to do the surgery when the tumor was growing before the deficit. Another example of ependymoma, it's a patient under bevacizumab for growing bilateral vesicular schwannoma. You see on the brain stem. And under bevacizumab, there is no cyst, but you can see the growth of the solid part. And I remove a part of this ependymoma because it was a big discussion with the patient, but I was able to remove a part of this ependymoma, and the patient is still under bevacizumab. In conclusion, we did not have the time to discuss on peripheral nerve schwannoma management, which is very important in NF2. And these are our conclusions. We think that NF2 needs to be managed holistically in expert centers, as performed in UK, in France. Surgery is the main option in NF2 patient tumor management and in many tumor types. What are the factors influencing surgical decision, except the surgeon experience? It's the tumor load related to the severity of NF2, the change to improve symptoms, and the risk of natural history and the risk of tumor growth. So I think that there is two cases of surgery in asymptomatic patient. In case of small, medium-sized growing VS with hearing preservation goal, and in case of growing asymptomatic ependymoma. When surgery is decided, it should be performed with the aim to resect the tumor, at least subtotally. I think that partial removal has no place in NF2. It's better to avoid surgery rather than to remove a small part. And as for every patient, we should have a maximal safety in this procedure. The risk of radiosurgery, radiotherapy is still discussed. It's not clear, even in the literature. And there is a risk of maybe malignancy that Andrew King will discuss based on his current experience. And what is very nice and give very hope for the future is that there are more and more medical treatment options in NF2 for vestibular schwannoma, for meningioma, maybe for ependymoma. So I'm sure that in the near future, the management of NF2 patients will be totally different with a lot of medical options. So it will be different, but maybe more difficult because we will have to deal with observation, surgery, radiotherapy, radiosurgery, and medical treatment. So it's why expert center will have a great place in NF2 management. Thank you. Now we will move to the question and answer based on these two presentations.
Thank you, Michelle and Andrew, for this very nice talk. We don't yet have questions coming up in the chat box, so I am going to ask a question myself to start with. And I was wondering if you could give us an idea of how many surgeries an average NF2 patient has to undergo in his lifetime.
I think it's different. It depends on the severity of the disease, and the severity of the disease is linked to the genetics. So the type of mutation is very important. So now we have to base our long-term management on the type of NF2 mutation. So if the patient has a mosaicism or the type of mutation, so there is a phenotypic score based on the mutation. I would say that I remember old paper showing maybe 7 or 8 surgery, but I think that less surgery is better. So I think that surgery remains something very important in NF2 patient management. It shows that I feel that at least in US, all the patients want a drug, a clinical drug. So yes, it shows that if we have such drug to freeze the disease is good, but I think that I'm sure that surgery will remain one treatment option in NF2, whatever the future will be. So I think we have some patients without surgery. So sometimes we have some patients, no surgery, and we follow them. And it depends on the severity, I would say.
Did you want to comment on this, Andrew?
One of the things I tend to do on Zoom is fail to take my mute off, sorry. So what I think is it absolutely depends on the genetic severity. What I think is that so when we'll have some patients who have had an operation, a major operation a year for 4, 5, 6 years, often young people in their 20s and 30s with severe disease, and 1 year it'll be an acoustic, 1 year a meningioma, etc., etc. What I think is the case is that quite a lot of people with NF2 who have multiple tumors have 1, 2, or 3 tumors that if you can deal with them well and safely, it will be transformational to their lives. Or put another way, who've had a complicated and bad outcome from surgery, and any surgeon can get a bad outcome, and the rest of their life is because of that. So the obvious one would be bilateral vestibular schwannomas, the hallmark of NF2, that if you can get those out and they get them out well, then notwithstanding hearing issues, which we've talked about, then their life is transformed. And I think that the message that perhaps Michelle and I would be absolutely sold on would be the 2 things that an expert centre does is try not to operate, but if you operate, operate properly. And radiosurgery, its role will be debated long after Michelle and I are gone, but it is not an excuse for doing a bad operation. And I think that's what I would say. Try not to operate, but if you're going to operate, take the thing out.
Thank you.
Maybe we can discuss, if there is no question, on for me, the most difficult case is a young NF2 patient with a small bilateral vestibular schwannoma. And it's always a big discussion because some neurologist experts will recommend early surgery, preserve hearing, but it's 50-50. So I feel very bad to decide a surgery in a very young patient when he's a teenager and with a risk 50-50 of losing hearing on one side and then you can have tumor growth. So for me, it's the most difficult decision and debate. So, you know, too small growing, and I think that nobody has a response. So maybe in such case, the medical treatment can be very nice, at least at the beginning. So it's for me, it's the most difficult decision.
Actually, we have now questions coming in. The first one is from Eleanor Roll, who asks if Avastin is an option for younger patients, for young kids, or is it better to wait?
I think we can say maybe yes, Andrew.
So yes, we certainly have in our cohort children in their teens. I think younger than that, not, primarily because there is very rarely in the UK experience, and I think it mirrors Michelle's experience, a need to do anything other than observe. That as with surgery, our inclination would be to do nothing. But certainly, children on Avastin, yes, absolutely.
But I think that for children, sometimes you see very fast-growing schwannoma, and in this case, Avastin seems to work less than in adults. So when you observe the cases of failure of Avastin, it's mostly in the very young NF2 patient with fast-growing vestibular schwannoma. Yeah. You can delay surgery, but it's a case where, no, what do you think you need?
Yeah, I agree completely. And I'm sure you have the same issue, but we've certainly got the odd one, the odd case where you have a rapidly growing young tumor and you take out the one and then put them on Avastin for the smaller one on the other side. And as I said in my part of the talk, there's no very great match between the two. So you preserve hearing for a longer period of time in one tumor, having done, if you like, the life-saving surgery on the other side. So it's not an either or. Sometimes you can do one and then Avastin.
Thank you. There's a question from John Manth, who asked, what would be a common scenario when you would use an auditory canal? Would that be decompression?
I don't understand exactly the question. It was about the decompression.
He says, what would be a common scenario for when you would use an auditory canal?
I think maybe it's auditory decompression. Yes, decompression. So we like to do decompression.
Okay. Sorry. Now yeah. The question, because, okay. The question is, what would be a common scenario when you would use an auditory canal decompression?
I think that we use the auditory canal decompression in case of no growth of the vestibular schwannoma, but decrease of hearing test or ABR, because you have a chronic compression of the cochlear nerve in the canal. So it's nice to enlarge the canal. So you have to drill through a middle fossa approach, open the dura, and sometimes you can devascularize the tumor. So it can prolong, maintain a serviceable hearing. It's impossible to improve hearing, but then you can manage, and it's good in case of hearing fluctuation. So you have sometimes patients with hearing loss, corticosteroid, recover hearing loss, and then we observe that you can stabilize hearing for a while. So it's it's used, and sometimes some teams add some removal of the tumor without taking risk, but I think that starting to remove tumor, it's always a small risk for cochlear nerve and facial. So we like to do only the decompression. But it's rare. In our center, we are doing this 2 or 3 times a year. So it can be helpful sometimes.
Andrew, would you like to comment on that?
We don't tend to do it in Manchester, not for any reason that we just don't. It's one of those options we've not employed. But Michelle's papers on it are very convincing.
I think that in the house clinic they started to do, Brackman started to do many years ago, and we rediscover this, and it's in some cases.
In your slides, there are no other questions coming up in the.
And just if I can add something, I'm not ENT, but I think that following the patient by audiometry with ABR, auditory brain stem response, is very important, because you can detect a risk of worsening of hearing if you follow the ABR. And sometimes the patient has a stable hearing, but you see something wrong on the ABR. And then we like to include this data in the management of patients. So if you have a patient with a stable VS, normal hearing, but you see something going wrong with ABR, so the ABR, you have a curve, and sometimes you see no curve, then you can predict that something will happen, and you can discuss decompression. You can maybe follow the patient more closely. So we like to include this. It's time consuming, but in the NF2 clinic, we add the ABR not systematically, but when they are present, to follow the patient.
Thank you. Since there are no other questions coming up, I wanted to ask you another question, because you were referring in your slides to many cases, to a few cases, a couple at least, where you said the patient arrived too late. There was this case of a child with a vestibular schwannoma that had grown too much, and that was difficult to operate. I was wondering if this was a common finding, that patients are referred to your specialist centers too late for an intervention that it would actually be more conservative.
Yes, it's still a difficulty in France. So we have 5 reference centers in France, but they are designated. So it's not, you are not obliged to go in this center like in UK. So in UK, the management of VS, you can say, is organized. You can be treated for VS outside the reference center. In France, it's totally different. So sometimes you have patients managed and with Avastin by neuro-oncologist or without nothing, and they arrive maybe too late, I would say. It's the same for ependymoma. But Andrew, it's a power of your organization led by Gareth Evans in UK.
Well, that is true. The major plus is that every patient in NF2 has to feed through one of the 4 centres: Manchester, Oxford, Cambridge, and London, and each one has spoke units outside, satellite units, if you like, but they have to report back in. So the answer is the system works very well in a way that you might find post-Brexit bizarre. The system is an English system, not a UK system. And I cannot sit here and make any defense of that at all, but it is the structure of the NHS that there's England, Wales, Scotland, and the Republic of Ireland, and Northern Ireland. But I think what does happen, in answer to your question, Marco, is that people don't appear late because people know of that system. And if anyone from Scotland, Wales, Northern Ireland wants to come in, then they do, and they do. So it is a credit to, you know, the father of NF2, really, Gareth Evans. I bask in his reflected glory in so many ways, but that setup was him and him alone that did that, and it's been great.
And you show an improvement of the survival of NF2 patients in the last decade.
Absolutely, that we've shown both improvement in quality of survival and survival since that system came in. Thank you. Yeah, absolutely. That is correct.
Thank you both. Eleanor Roll came up with another question. Does the ABR technique exist to test other nerves than?
No, you can test only auditory brainstem response. So you can test hearing on the cortex. For the ependymoma and the spinal cord monitoring, you can use motor evoked potential or sensory evoked potential. So you can detect something wrong in the spinal cord, and you can use this monitoring during surgery. So you do before surgery, and then when you do the spinal cord surgery, you can monitor your surgery, and you can see if something is bad or not. And so ABR, it's auditory brainstem response. So it's for the cochlear nerve and all the auditory pathway.
Well, thank you. And I wondered if you had anything, any questions that came up, actually you wanted to further comment on them before?
Sure. Sure.
Eleanor Roll, thanks you for your answers. And the hour is coming up, so I think unless another question comes up, this masterclass is now almost finished. I wanted to take the opportunity to tell the audience that the info program is now, this is the last masterclass until the summer. We will come back with masterclasses on NF2 and schwannomatosis, specific ones, in September, October. So please do check our website, and we will notify everyone in the mailing lists, of course, as soon as we have dates for these masterclasses. This very masterclass will be put on the YouTube channel in a week or so in all 7 languages, and you will get an email as well if you want to come back to it. I want to thank you very much, Andrew and Michel, for this very nice lecture, and the audience for being here and for their questions and their interest in NF. And hope to see you back soon, very, very soon.
Thank you.